Have you ever seen a young, otherwise healthy patient walk in with surprisingly high blood pressure? It makes you stop and think, right? Well, one of the classic congenital causes you just can't afford to miss is coarctation of the aorta. Today, we're going to break this whole thing down from top to bottom.
You know, high blood pressure in a young person is a real clinical puzzle. It forces you to look way beyond the usual stuff like lifestyle and age. Coarctation of the aorta is a major piece of that puzzle, and honestly, understanding it is so crucial.
So here's our game plan for today. We'll start with the basics. What even is this? Then we'll dive into how it works and what it looks like in a patient. After that, we'll cover diagnostics and treatment, and we'll wrap it all up with a super high-yield summary for your exams. Okay, Section 1. What are we actually talking about here? Before we get into all the complicated physiology, let's just start with the fundamental problem, the anatomy itself.
At its core, coarctation is basically a pinch in the body's main blood highway, the aorta. It's a congenital thing, so you're born with it, and it almost always happens in a very specific spot, the aortic isthmus, which is right after the big artery that supplies your left arm.
And don't go thinking this is some super rare, once-in-a-career diagnosis. Nope. Coarctation accounts for about 5 to 8% of all congenital heart defects. That means you are very, very likely to come across this.
So this pinch, this obstruction, creates a classic plumbing problem. Just imagine you're watering the garden and you step on the hose. What happens? The pressure builds up like crazy before your foot while the water just trickles out the other end. That single idea, high pressure before the block, low flow after it, is the absolute key to understanding everything else about this disease.
So, how does one little kink in a tube lead to such dramatic effects all over the body? Well, let's dive into the pathophysiology and see how this one anatomical flaw kicks off a whole cascade of changes.
So how does this even form in the first place? Well, the most accepted theory takes us way back to fetal development. Step 1, tissue from a temporary blood vessel, called the ductus arteriosus, kind of grows into the wall of the aorta, where it shouldn't. Step 2, after the baby is born, that ductus naturally closes up. Step 3, that misplaced ductal tissue constricts right along with it, pinching the aorta shut from the inside out. Now, clinically, we classify coarctation based on where it is in relation to that ductus. We have pre-ductal, which is what we typically see in infants. Their lower body blood flow can be totally dependent on keeping that ductus open. We call that PDA dependent. Then there's post-ductal, which is more common in adults, where the body has had years to adapt by growing this whole network of detour vessels to get around the blockage. This whole situation creates what I call the great divide in the body's circulation. The heart is just pumping like crazy against that blockage, causing really high blood pressure in the upper body, the arms, and the head. This can show up as headaches or even nosebleeds. But at the same time, the lower body is starved for blood flow, leading to low pressure, weak pulses, and legs that get tired and cramp up really easily. But you know, the body's pretty resourceful. It fights back in two main ways. First, to get around the traffic jam, it builds an incredible network of backup vessels or collaterals, often using the arteries that run right alongside the ribs. At the same time, the heart's main pump, the left ventricle, is basically at the gym 24/7, working against all that pressure. This intense workout makes its muscular wall get super thick, a condition we call left ventricular hypertrophy, or LVH.
Okay, with all that physiology in your head, how does this actually look in the clinic? Let's talk about the patient who's right there in front of you.
The presentation is dramatically different depending on the patient's age. It's like night and day. In a newborn, when their ductus arteriosus closes, they can suddenly crash. They'll have poor feeding, breathe really fast, and can even go into heart failure and shock. But in an older kid or an adult, the symptoms are way more chronic and sneaky. Things like persistent headaches, dizziness, or just getting tired legs way too easily during exercise.
Now listen up, because this is the money shot for your physical exam, the absolute classic pathognomonic sign, and that means it's pretty much diagnostic for the condition, is radiofemoral delay. Because the blood has to take this long, winding detour through all those collateral vessels, the pulse in the femoral artery in the groin arrives noticeably later and feels weaker than the pulse you feel in the radial artery at the wrist. It's a dead giveaway.
So, putting it all together on your exam, you're going to feel for that classic blood pressure difference. High in the arms, low in the legs. You'll notice those femoral pulses are weak, or maybe you can't even feel them at all.
And if you listen with your stethoscope on the patient's back, right between the shoulder blades, you might just hear a systolic murmur from all that turbulent blood trying to squeeze through that narrow spot.
Okay, so your physical exam has you highly suspicious. How do you actually confirm it? Let's decode the clues from our diagnostic toolkit.
The chest X-ray gives us some classic buzzword findings that are perfect for exams. The first is the figure 3 sign. The aorta's shape with the little indentation from the coarctation and the dilated parts above and below it literally looks like the number 3. The second one is rib notching, and this is so cool. It's caused by those powerful collateral arteries along the ribs pulsating for years and years, slowly eroding the bottom surface of the ribs. The ECG gives you a window into how the heart is coping with all this. Remember that left ventricle working overtime? Well, that chronic pressure overload causes the muscle to thicken, and this left ventricular hypertrophy creates a classic telltale signature on the ECG tracing. But the gold standard, the test that really seals the deal, is the echocardiogram. This cardiac ultrasound is the definitive tool. It lets you literally see the narrowed segment, you can use Doppler to measure the pressure difference across it to see how severe it is, and, this is crucial, it lets you screen for other heart defects that often come along for the ride. All right, we've got a confirmed diagnosis. So what's the plan? Let's talk about management, and also the other high-risk conditions that you always need to have on your radar with these patients.
And these associations are incredibly high yield for exams, so listen up. A bicuspid aortic valve, where the valve has 2 leaflets instead of 3, is extremely common. Turner syndrome is a key genetic link. And very, very importantly, these patients have a higher risk of developing Barry aneurysms in their brain, which puts them at risk for a really devastating type of brain bleed. The treatment strategy is really tailored to the patient. First, for a newborn in distress, the immediate life-saving step is to start an infusion of prostaglandin E1. This medicine reopens that ductus arteriosus and gets blood flowing to the lower body again. Second, the definitive fix is usually surgery, often by cutting out the narrow part and sewing the healthy ends back together. And finally, for some older patients, there's a less invasive option, using a balloon to stretch the area open and placing a stent to keep it that way. All right, let's pull all of this together into a final high-yield summary. Think of this as your exam blueprint. So let's lock it in. Coarctation. It's a congenital narrowing of the aorta. The key pathophysiology is that great divide. High blood pressure in the arms, low blood pressure in the legs. Your classic physical sign is that radiofemoral delay. On an X-ray, you're looking for the figure 3 sign and rib notching, and you always have to think about the key associations: bicuspid aortic valve, Turner syndrome, and Barry aneurysms. Treatment? Prostaglandins for babies in trouble, followed by definitive repair with surgery or a stent. It's truly amazing when you think about it, how one single localized anatomical defect can cause such profound and widespread consequences throughout the entire body.